This is Professor Saskin. We're here to talk about congenital heart defects. There are four basic congenital heart defects, depending upon the type of blood flow. I'm going to start with the congenital heart disease itself and how the child develops congenital anomalies. So, contributing factors are maternal factors, which would be infection early in the pregnancy when the embryo or fetus is developing, alcohol or substance abuse during pregnancy, and diabetes mellitus of the mother will increase her risk for the child being born with a cardiac defect. Genetic factors, family history of congenital heart disease, presence of other congenital anomalies or syndromes. A lot of times congenital anomalies go hand in hand with various organs, depending upon when the organ is developing in utero. Now, the first type, we have decreased defects with increased pulmonary blood flow. So we have patent ductus arteriosus. Patent ductus arteriosus, you have the failure of the fetal ductus arteriosus to close within minutes or a few days after birth. Size can vary in the defect. So you have a left to right shunt. All of the increased pulmonary blood flows, defects, have left to right shunts. So blood shunts from the aorta to pulmonary artery. You have oxygenated blood from the aorta mixing with the deoxygenated blood from the pulmonary artery. The baby will develop respiratory distress, a machine hum murmur, bounding pulses, widened pulse pressures, poor feeding, and asymptomatic or signs of heart failure. Treatment is going to be indomethacin. Administration of ibuprofen can be used in premature infants. Insertion of coils to occlude the PDA through a cardiac catheterization, and if needed, surgical repair, which would be a thoracoscopic repair. Ventricular septal defects. You have an abnormal opening between the septum of the left and right ventricle. Also, size will vary depending on the size of the opening. Blood shunts from the left to right ventricle and back into the pulmonary artery. So you can have oxygenated blood mixing with the deoxygenated blood, and then it's pumped back into the lungs instead of the systemic system. You have increased pulmonary vascular resistance, right ventricular hypertrophy, and potential enlargement of the right atrium from the backflow of the blood. You have a loud, harsh murmur at the left sternal border. You have mild cyanosis that can increase with crying and heart failure. Treatment is closure during a cardiac cath. Surgical procedures will be pulmonary artery banding or complete repair with a patch. Atrial septal defects. You have abnormal openings in the septum between the atria and the two atrias. Blood shunts from the left to the right atria and flows back to the right side of the heart. You have oxygenated blood from the left atria mixing again with deoxygenated blood from the right atria, and it increases the total amount of blood that flows towards the lungs. Blood is pumped back into the lungs instead of flowing to the systemic system. Child can be asymptomatic. It may go undiagnosed until adulthood. The child will have a murmur, shortness of breath with activity, frequent respiratory infections, dysrhythmias, heart palpitations. Closure, it's generally treated by closure during a cardiac cath or surgery with a patch closure. Defects with decreased pulmonary blood flow. These are tetralogy of Fallot and tricuspid atresia. Tetralogy of Fallot has four major defects: pulmonary stenosis, ventricular septal defects, overriding aorta, and hypertrophy of the right ventricle. So you're going to have a shunt that goes from left to right or from right to left, depending upon the defect. Left and right ventricle pressures may be equal if you have a large VSD. High pulmonary vascular resistance from the right to left shunt. High systemic vascular resistance if it's left to right shunts. Decreased blood flow to the lungs and the amount of oxygenated blood returning to the left side of the heart from the pulmonic stenosis. Each ventricle will distribute blood to the systemic system, but it depends on the positioning of the aorta. So the child is going to be cyanotic and have hypoxia spells or TET spells. When the child has a TET spell, if they're old enough, they'll put themselves in a knee chest or kneeling position, which helps relieve the hypoxia. If it's an infant, you need to hold the baby in a knee chest position to help until the TET spell resolves. Heart sounds vary depending on defects. They'll have cardiomegaly, heart failure, and a systolic murmur. Treatment is a palliative shunt in early infancy until they're old enough to have a full repair, which is generally completed within the first year of life. Tricuspid atresia, you have complete closure of the tricuspid valve. So you have a mixed blood flow. Infants will be cyanotic, have dyspnea and tachycardia. Older children, you're going to see hypoxemia and clubbing of the fingers due to the chronic hypoxia. The third type of defects are defects with mixed blood flow. There are three basic types of defects. Transposition of the great vessel. So you have two main arteries are reversed. The aorta exits the right ventricle instead of the left, and the pulmonary artery originates from the left ventricle instead of the right. So you're going to have no exchange between systemic and pulmonary circulations. Aorta exits from right ventricle and carries the deoxygenated blood back to the body. Pulmonary artery originates from the left ventricle and carries oxygenated blood from the lungs back to the lungs. Results in inadequate oxygenated blood in the body. PDA or septal defect may be present for blood to enter the systemic or pulmonic circulation. Manifestations, you're going to have cyanosis. Heart sounds will vary depending on the defect, cardiomegaly, and heart failure. Generally, they're going to treat this with intravenous prostaglandin E to keep the ductus arteriosus open, balloon arterial septostomy, surgical arterial switch, and this is done within the first weeks of life, and then other surgical procedures depending upon the defects present. The second condition is truncus arteriosus. So you have failure of septum formation. So you have a single vessel coming off the ventricles. This causes heart failure, murmur, cyanosis, delayed growth, lethargy, fatigue, poor feeding habits. Hypoplastic left heart syndrome. According to ATI, hypoplastic left heart syndrome, the left side of the heart is underdeveloped. You have an ASD or patent foramen oval allows for the oxygenation of the blood. The child will have mild cyanosis, heart failure, lethargy, cold hands and feet due to poor circulation. Once the PDA closes, you're going to have increased cyanosis, decreased cardiac output, and eventually cardiac collapse. So hypoplastic left heart syndrome generally has a poor outcome unless the infant is able to have a heart transplant. Next, you have defects with obstructive blood flow. These are coarctation of the aorta, pulmonic stenosis, and aortic stenosis. So coarctation of the aorta. You have narrowing of the lumen of the aorta, so you get obstruction of blood flow from the ventricles. And you have increased pressure proximal to the defect So you have increased pressure in the upper extremities. You have decreased pressure in the distal to the defect or the lower extremities. Upper extremities, you're going to have elevated blood pressure, bounding pulses. Lower extremities, decreased blood pressure, weak or absent pulses, cool skin. The baby is going to be dizzy, syncope, headache, epistaxis, and heart failure are other symptoms. Treatment with infants and children, they do a balloon angioplasty. Adolescents, they put stents in. Surgical procedures, you're going to have repair of the defects, which are recommended for infants less than 6 months of age, preferably. Pulmonic stenosis. With pulmonic stenosis, you have narrowing of the pulmonary valve or pulmonary artery, so you get obstruction of blood flow from the ventricles. The child will have a systolic ejection murmur, be asymptomatic, most likely. Cyanosis, if the defect is large, with severe narrowing, cardiomegaly, and heart failure. Aortic stenosis, you have a narrowing of the aortic valve. Infants, they're going to have faint pulses, hypotension, tachycardia, poor feeding tolerance. Because it takes so much effort for them to breathe, they don't have the energy to eat. Children, you have intolerance to exercise, dizziness, chest pain, and an ejection murmur. With coarctation of the aorta, this is generally diagnosed in the newborn, because one of the procedures we do with a newborn is to take blood pressures on all 4 extremities to see the difference. That is the earliest sign of coarctation of the aorta, is the difference in the upper and lower extremities of blood pressures in newborns. Okay, now the next one topic I want to talk about is heart failure in children. So you have impaired myocardial function. You're going to see on assessment, nursing-wise, impaired myocardial function, sweating, tachycardia, pallor, cool extremities, weak pulses, hypotension, gallop rhythm, cardiomegaly. Pulmonary congestion, you're going to see signs of tachypnea, dyspnea, retractions, nasal flaring, grunting, wheezing, cyanosis, cough, orthopnea, and exercise intolerance. So orthopnea is when the child will put themselves in a position, generally it's like a tripod position, which helps them to breathe. Systemic venous congestion, you're going to see signs of hepatomegaly, peripheral edema, ascites, neck vein distension, periorbital edema, weight gain. Now, care for child with heart failure. You want to help conserve the child's energy. You want to give them frequent rest periods, so we need to do cluster care, nursing-wise, which means you gather what you're going to do, you do as much as you can in a short period of time, and then you leave the child to rest before you disturb them again, which helps conserve their energy. They need small, frequent meals. Bathing is done PRN, and you want to keep crying down to a minimum because crying will increase cyanosis in children. Daily weights and eyes and nose. Weights need to be done at the same time on the same scale, either naked, depending on the age of the child, or in the same clothing every day to be consistent. You want to allow the child to sleep with pillows in a semi-Fowler's position, and keep them, and when awake, they should be sitting up or semi-Fowler. Allow the infant rest periods during feedings, because again, feedings expend energy, and the child may not be getting in enough calories to cover the energy being expended out for the eating process. So it takes at least 30 minutes per feeding to feed a child in heart failure. Gavage feedings may be needed, so you want to use a high-calorie formula. So to gavage feeding, they'll either do NG tube feedings as ordered with a 24 to 27 kilocalorie per ounce formula to increase the amount of calories per feeding. Administer humidified oxygen. Monitor oxygen sats every 2 to 4 hours. Suction PRN. But remember, when you suction and they're hypoxic, you need to hyperoxygenate prior to suctioning and then oxygenate again after you suction. Monitor family coping and provide support. Teach the family to report the signs of worsening heart failure, such as the baby has increased sweating or diaphoresis, decreased urine output. Okay. Thank you, and have a lovely day.